topic is Re-Endo in periprosthetic fractures. As we all know, the periprosthetic fracture is a nightmare for the patient as well for the surgeon because it creates significant morbidity for the patient because patients usually comes to us for the better quality of life after TKR surgery. So overall incidence of periprosthetic fracture is 0.5 to 4%, and femoral supracondylar periprosthetic fracture are common than tibia. So number of risk factors have been identified that predispose patients to fractures, most commonly seen in female patients because all elderly females, Indian patients are having severe osteoporosis. Patient-related risk factors like osteoporosis and chronic steroid use, rheumatoid arthritis, neurological patients, they have tendency to fall frequently, fall down and they got the fracture. So in addition to systemic factors, stress rises like osteolysis in, around the femur, screw holes, previous osteosynthesis, due to previous osteosynthesis. Anterior femoral notching is again a very predisposing factor for periprosthetic fracture of femur. And as compared to the implant, PS implant having the high incidence of periprosthetic fracture as compared to CR joint because the box itself creates the stress for predisposing for fracture. So there are a lot of classification for the periprosthetic fracture femur. We follow the Kim's et al. Classifications. They divide into 3 categories: type 1, type 2, and type 3. In my case series, I operate 3 patients where I'm going to show you. The type 3 patient, unstable with poor bone stock patients. This all classification depends on the displacement, bone stock, component stability, and ligament integrity. So according to this thing, we can choose our plan for periprosthetic fracture treatment. So this is algorithm for the treatment plan of periprosthetic fractures. So broadly, we divide the fractures in 2 categories, where bone stock is good enough in distal part, then osteosynthesis is the option. If the bone stock is very less, component unstable, and integrity of ligament is gone, then we can choose constrained, semi-constrained, or either primary implant for the revision surgery. So mostly patients with distal comminuted fracture ended with this, and the choice is RHK implant, but I'm not convinced with it. It should be the last options until unless any other option is left. So I'm not a favor of the RHK implant, rotating hinge implant in periprosthetic fractures. So because the biomechanically any increase in the constraint of the prosthesis also increases capability to transmit load through the bone fixations. But it is preferred to the load transmission by the soft tissue stabilizers. So as we increase the constraint, also increase the stress at the bone and implant junctions. So, and it reduces the longevity of the implants. Thus, it is recommended to use the least amount of constraint as possible as we can. So, what we did in our series of 3 patients, in case of distal comminuted femur fractures with the loose prosthesis, most of which are insufficiency fractures, we opted delayed treatment for initial fracture healings. I kept all patients in the plaster for 6 weeks. For that, we need good counseling of the patient, because the hypothesis is after putting the 6-week in a plaster, the all soft tissue sleeve become fibrous and it gives the good stability for your both collateral ligaments, and sometimes you can convert in the simple revision surgery. So this is case number 1, simple primary osteoarthritis, bilateral TKR had been done, nicely, well balanced. After 10-15 days around before suture removal, she landed up with this highly unstable periprosthetic fracture. Both epicondyle is separated, component is floaten, there's highly unstable fractures. So I kept this lady for the 6 weeks in plaster, and along with teriparatide injection for 6 weeks. After 6 weeks, I revised her with simple primary revision implant with long stems and fixed the condyles with screws. Tibia left untouched. Okay, and after this is the first follow-up, 2 months follow-up, 3 months follow-up, and she able to walk. She has good range of movement and good alignment. This is case number 2 and 3 have similar kind of periprosthetic fracture femur, highly unstable. So in our series, with the after delayed treatment, we have allograft to reconstruct the distal part of femur with help of the screws and sometimes to balance the joint line. So we use augment also. Because allograft have the similar osteoconductive, osteoinductive and biomechanical property to the original bone as compared to origin bone. So after the case 2 have seen the first follow-up, case 3 also have well alignment implant, 2 months, 3 months follow-up, and their patient was doing good, you can see. So in series of 3 patients, our management strategy, which involved delayed treatment for initial fracture healing, followed by femoral compound revisions, was found to be an effective approach and prevented the further need of distal femoral replacement. The average follow-up was 3 months. Average flexion was around 100 degree. No flexion contracture was reported in any patient. No tertiary revision was required till date. So my take-home message, the post-TKR periprosthetic fracture surgery needs extensive pre-operative planning. Keep option A, B, C, go into surgery with semi-constant and constant implant as a backup, not as a first option. Try to achieve desirable result with minimal constant implant as possible. The technique we discuss is a good option for comminuted distal supracondylar femur fractures, post-TKR, mostly insufficiency fractures. Thank you very much.